Good afternoon, everyone. I'd like to welcome you to this afternoon's first super session entitled Executives Unplugged. Where's the disconnect between mHealth and mobile technology? I've got a great panel here this afternoon, and what we hope to do with your engagement is to literally have a conversation. Are we unplugged? Is technology working? Can it work? How are we going? What are our suggestions for making it work? And I look forward to your engagement. We look forward to creating a conversation for the next hour. We've got some mics here in the center, so please, at any time, don't hesitate to come on up and join the conversation. We'd be very, very appreciative. I'm Pat Wise. I'm Vice President of HIMSS and mHIMSS. For those of you who are not familiar with HIMSS, HIMSS is a not-for-profit, a global not-for-profit organization that has more than 45,000 individual members, more than 500 corporate members, and we focus on creating tools and resources for the betterment of healthcare through IT. And it is my true delight to see so many of you here today. With that, I'm going to ask my panel to introduce themselves, and we'll go down the line. And Rob?
Good afternoon. My name is Dr. Rob Lamberts. I'm actually not an executive. In fact, I'm actually a practicing primary care physician. I recently actually quit my practice, 18 years, a profitable practice, doing traditional medicine, and have over the past few months been building a new type of practice where we charge only a flat fee, $50 give or take, per month for all primary care services. It's really an old-fashioned view of things, but I'm really going to be using a lot of technology in what I'm doing and have been designing it. And why I'm up here is because I know Pat from I actually was the lead physician in getting our practice in Augusta, Georgia, to be a Davies Award winner from HIMSS. And I do want to leverage technology as much as possible. I'm leaving because I have strong feelings about the payment system and how it affects my ability to use that technology. I really can't use that technology because in the traditional system. So in some ways I'm the foil up here, or the snarky guy who's going to give, but also I'm trying to be the reality of what's going on, because it's the face-to-face with patients that had gotten me away from the traditional type of a practice to the type of practice that I'm going to. I want to spend my time more with my patients. So that's all.
Great, thanks.
Hi there, good afternoon. First of all, just want to say thank you to Pat and for HIMSS for inviting me to be here. My name is Geetha Nair. I'm the Chief Medical Information Officer for AT&T. Also a practicing physician. My background is as a rheumatologist. I am on faculty at George Washington University here in the district, and a big believer in health IT, a big believer in mobile health, but also a big believer in patients and better health care and better outcomes. And my role with AT&T is really to do just that, to bring a clinical lens to our products and solutions so that we can make a broader impact on healthcare. Thank you so much.
And I'm Al Shar. I'm currently a vice president at the Robert Wood Johnson Foundation, foundation focused exclusively on improving the health and health care of all Americans. Prior to that, I was in charge of research at a Johnson & Johnson pharmaceutical firm, and prior to that I was at the University of Pennsylvania Health System for 13 years, where I set up a program in medicine and computers. Desperately interested in this field, and interested because there's something that presents a promise of allowing us to wind up transforming healthcare and health in general in a way that we've never been able to do before. I desperately want to help that dream occur. I think that there are obstacles, and I think we need to wind up figuring out what those are and how we need to make them disappear as quickly as possible.
Good afternoon. My name is Samir Damani. I'm a cardiologist and an NIH-supported researcher. I'm also the CEO of MD Revolution, which is the first company in the world to systematically integrate genetic information, mobile health technologies, and connected software solutions for preventive care. Our mission is to really shift the paradigm of medicine from one that is delivering reactive disease care to one that's proactively healthcare driven, and to help scale that model for corporations, for physicians, and anybody looking for wellness solutions that's based on evidence and science.
Thank you all. For those of you who've just come in the last few minutes, we truly hope to have a conversation here, so please avail yourself of the use of the mics in the center. Join our conversation. We're open to questions and look forward to them. Samir, don't let that mic get too far away from you, because I'm going to ask you the first one, which is, can mobile technology truly be harnessed to improve cost efficiencies and care outcomes? And can you, if your answer is yes, can you speak to how the design and the mobile ecosystem can help improve the mHealth aura, help us shine, help mHealth to shine?
Sure, that's a great question. So, I think in order to, you got to back up from the financial question. If you really want to understand how mHealth is going to improve costs, you got to look at the problem. And the problem is one of chronic disease. I mean, you got a $2.6 trillion annual U.S. healthcare budget. 75% of that is taking care of chronic disease. So if you're going to improve costs, you got to say, okay, what is it that is going to reduce the impact of chronic disease? And if you look at the epidemiologic data, it really comes along the lines of behavior and lifestyle approaches. Well, it just so happens that mobile health technology and genetic information is very motivational. It also provides a form of biofeedback that has never heretofore been possible. So the answer to that is yes, because what you have to start doing is saying, okay, if you can take the individuals who are pre-hypertensive and bring to light that they're pre-hypertensive, if you can get them to say, I've been sitting all day, I need to walk more, if you can motivate them through social networking and connections, then all of a sudden you can really reduce the cost of health care, because now doctors are delivering preventive solutions and not delivering reactive disease-based solutions. And so I think also we have to understand that the ecosystem has to start somewhere, and that's one of the things that we're trying to do, is really build that model to show people, what does this look like? What does that ecosystem look like? You got to go out and try it, and you got to show outcomes. And I think if you can show outcomes on what that ecosystem looks like, I think the potential to reduce costs from the impact of healthcare on a population health management standpoint is huge. I don't know if that answers the question.
Well, it's a great start on the question, and certainly is. Al, from your perspective at Robert Wood Johnson, have you seen any technologies or any ways that we can help expand the ecosystem for patient engagement?
Sure. I think we've seen, and I'm going to change the question a little bit because that's my prerogative.
Absolutely.
I think that there is tremendous potential, and I think that the title of this session, it really holds what is a key. I don't think there's any place where there is a bigger potential for gain in bringing together health professionals and technologists for a real and significant return on the health of this, on health in general and on health care. I do think that there are problems. I think that often technology and health professionals use the same words and speak different languages. That presents a problem. We have to find a way to make those groups speak together, understand. We have to wind up making sure that we understand the nature of what collaboration really should wind up being. Collaboration is not that each is an equal partner. It's that each has a role that's extremely important in terms of moving this forward. And at the bottom of this is we must wind up providing a platform that shows that there's evidence that this actually does some good.
Rob, let me ask you, you mentioned in your introduction that you left your practice because you did not believe the payment system could work with you so that you could use the technologies that you wanted to use to take care of your patients. Could you speak some more about that, and how do we help you with that in the ecosystem?
Well, I mean, I think one of the main problems that it's far too profitable to be inefficient and far too profitable to be complicated. And I really don't think that there's any way the system, any tool that makes things simpler won't be embraced unless it actually is better to be simpler. And as a physician, if simplicity means that my patients are staying away from me in the office, well, that really ends up meaning that I make less income, or I have more opportunities to interact with them outside of the office setting, which is great for the patient. It's great for the insurance company because they don't have to pay me, but I spend all my time doing something that I don't get paid for. And I really believe for any technology to actually be adopted, there are really two, especially mobile technology, there's actually two markets, people that they really have to reach. And one is the reluctant physician. Because I was embracing EMR in 1996. I was preaching it and, I'm a recovering evangelist for EMR. But the truth is, it's the reluctant physician out there who has been the hard one to get to do electronic medical records. And even using a big cash stick like Meaningful Use has made it very hard. But if you can somehow make it in their best interest to use the technology and also make it so that you can reach grandma, and I use that just as an example, but it's pretty much reached not the technophile, but the technophobe, where it actually is easier. I mean, my mom is 85 years old, and she knows how to drive a car, which is far more complicated than, although I don't know if I'd want to ride with her at this point, but that's far more complicated than booking flights on Delta.com or whatever, and she does that. So why can't we find a technology that enables it both ways? But to answer the question, I think that the root problem is the payment system that is one of those things that the more I do, the more I get paid, and the less I do, the less I get paid. And until that fundamental problem is solved, and I've solved it by kind of rebelling against the system, but until the whole system is somehow changed to a paradigm where it's actually in people's better interest or in economic better interest to not do things rather than to do things, then, we're going to get what we're paying for, and we are.
Are there any, and Geeta, I'm going to ask you because I know you spend so much time taking a look at this, are there any design elements, Rob, I hear you, that the payment system is in need of reform to make this work, but can we make mobile more accessible for patients? Is there anything in the design system, in the ecosystem, that can help foster patient involvement, customer involvement, client involvement?
Sure. So thank you, Pat, for the question. Again, I apologize. I'm recovering from a pretty bad cold, so bear with me, reminding everyone we are all patients, right? I think that's a terrific question, because I would say that as a physician, as a practicing physician, there's really no one-size-fits-all. So when I see a 75-year-old patient with osteoarthritis, I don't know that patient is really going to go towards a gaming technology or a gaming mobile health application that's going to help her get out and about. That's probably not going to fit for that patient. But when I have a 19-year-old lupus patient who doesn't like to have lupus, doesn't like to take her medications in front of her friends who, for the most part, are healthy, if there's any sort of tool I can put in her hands that helps her engage with other lupus patients, engage in ways that will help her disease and prevent acute episodes, that's what I'm looking for. And with regards to the design element, I think it's about going from these one-off siloed mHealth applications, for which there are gazillions out there, and really going to sponsored applications. So I think the trend that we're going to see is this idea that we don't want to go from these paper-based silos to now digital-based silos, right? We want to have these mHealth applications be sponsored by providers, by payers, have them be integrated, have them actually connect patients, because that's really the value. And it's not going to be a one-size-fits-all. There's not, because the way the market is right now and the consumer is right now, we're all in a different place of sophistication. And sometimes simpler is better, because, again, right now we're working with paper-based systems, so to go up from that, we don't necessarily need the shiniest and fanciest thing. We just need something better than paper. And the biggest value that the digital age can bring is those connection points that paper can't.
From your perspective, we're going to make Rob the switchboard here. From your perspective, have you seen any design elements that can help engage the patients?
No, I think it's, I think we need to think about Apple And, you know, it's all design. It's actually 100% design because the technology is there. The disconnect is that the technology is not built for the service that needs to be delivered. And the service is delivering outcomes. So you're absolutely right, Geetha. When you talk about siloed solutions, I mean, pedometers, they're all siloed. The weight scales, wireless scales, heart rate monitors, these all have great impact on how you can live your life, and it provides feedback. But the problem is they're all siloed. One goes to, you know, you have a Withings monitor that goes to one app. You have a DigiFit device that goes to another app. You have a pedometer that goes to another app. I mean, how can you as a physician or a practitioner monitor, motivate, and measure using a system that's fragmented? And that's what we actually are doing. We have a software system that we've developed that brings those elements together. We're using the Qualcomm 2Net platform actually to push that data to our actual software where you can see your lab data. You can see your 23andMe data. We're working with that to bring that in. You can see your step data. You can see it all in one place. You know, and then the health side, instead of an EMR system, which is really built for an administrator, right? Let's build it for patient engagement. Let's actually let the patient see their data, right? So the design is critical because it's got to engage the patient. And then on the back end, you need to be able to have the health team serve as a coaching mechanism, not as a doctor. It's not about the doctor, it's a healthcare team. So now all of a sudden, when somebody puts on 5 pounds of weight, your healthcare team gets a message saying, oh, you know what? Because it's automated, right? You can do that today. You couldn't do that 5 years ago. So corporate wellness settings, all these types of settings, it can be used immediately. And since 60% of employees or 60% of people in this country get insurance through their employer, right? So immediately the design element needs to engage those individuals through the use of innovative software and design to bring it all together, because right now it's really a disconnect. It's fragmented. And we need to bring it, we need to connect the dots.
Yes, now.
Yeah. Several things. First of all, design is absolutely critical. We're in a state where there's tremendous growth, and you know, periodically you'll hear the "let 1,000 flowers bloom" metaphor. By the way, that was Mao's metaphor, and the reason that he used it was to wind up finding out those dissidents that he could then purge. That has not a lot to do with mHealth, but it is critical that we're able to wind up moving, having design elements, having all of the infrastructure that's necessary to move things so that the transactions are as invisible as they can be, are as independent of what any particular application can be, that they build upon each other. That's one of the reasons why we're funders of Open mHealth, which is which I encourage everybody to see their exhibit. The other piece that I think is, again, absolutely important is to recognize that everyone is an individual, and you can design for that. The other thing about the space that we're in today with regard to health is, whether we like it or not, we as individuals are going to have to take more control of our own health. We have to take more responsibility. If we want to be healthier both as individuals and as a population, we have to wind up taking that responsibility. There isn't a technology that enables that anything more than mHealth.
Rob?
Yeah, two things. First off is that there's this idea of the collaborative health record, which I think is actually the most accurate. As again, an ex-EMR evangelist, and I say ex because I really have moved on to a collaborative record. I do believe in the open notes study that talks about giving patients their information, and I do plan on making every bit of information I get as much as possible accessible to my patients so that they can then pass it on so that they have it accessible. I think it needs to be a collaborative record, and that needs to be something that is easy to do for both the physician or any other healthcare provider for that, and the patient, a collaborative idea. And if you think about, the second is that if you really think about what mobile technology does, mobile technology really accomplishes two things. The first is communication. It enables communication. You walk around with your phone. And the second thing it does is it addresses the accessibility issue, and that's not quite the same because it's accessibility to your data, whether it's getting it out or putting it back in. It enables that communication, and so if I can enable it so one of my little old ladies just pushes a little button that says talk to Dr. Lamberts, and it automatically opens up a chat session, she can do that. And if that's not something that's all that difficult, I do think design is key. We think of Apple. The other thing I think about is ATM machines. I mean, did we have to have a meaningful use program to get people to use ATM machines? Or, you don't have to have meaningful use to incentivize people. The minute you use the word incentivize, you've already lost the battle. Because that means that you got to kind of almost force people and coerce people to do something. If it's downhill, the car's going to roll. And that's really what technology needs to do. When ATM machines came out, there were a few stick-in-the-muds who always ended up in front of me writing a check in the cash line or buying groceries. But the reality is that it was so much easier to do the other thing. And so technology has that ability. It just needs to get over the hump.
Yeah, and I just want to add one more thing about the design element. I think there's two ways to look at design. One is how do these pieces fit together to deliver outcomes? So you got to almost build a clinical lab and start using this technology to do it and make sure that what you're delivering actually has outcomes. So it's not about the technology, it's about the delivery of the technology. So that's one element of design, and I think the software solutions are critical for that. I think that the software doesn't exist. We don't need EMR systems. What we need are digital health companions. We need a patient engagement platform. So that's one design element. But I think the other element is make it fun. I mean, you're talking about incentive. You're absolutely right. I mean, if you're talking about incentivizing people, you've lost the battle, because essentially what you really need to be talking about is we go to the Apple store because we like to. Why the heck is it that the one thing that matters to us most, which is your health, is considered the least fun? I mean, I don't know, I don't even like going to my doctor, So the idea is that, most people don't like going to the doctor, and I think because we have to shift the paradigm. So the design element with mobile health is it can make it cool. It can make it fun. It can make it exciting. And so I think that, beautifying it, making it, and I think the concierge physicians are a great way to actually leverage that, where they already try to bring design and a personal touch to it. So we need to personalize it. We need to take mHealth, which is a technology, a chip, accelerometer, and make it something that has a life, and I think, and so the design is both in bringing tools together to deliver, but then also the design element, like we think of anything that's beautiful, make it fun.
Our topic here is where's the disconnect? We just heard about design. Is that the only disconnect? If we mastered design, would we be there? Al?
Unfortunately, no. As I mentioned before, we have a language problem. And I've been in the trenches seeing this. I've been to meetings where we try and bring people together who can all contribute and all want to contribute, but there is a language problem. The language of healthcare is dealing with a set of subtleties. The language of technology deals with a set of precision. And the only way that you can actually make those things work is to make sure that people pay attention to each other during the entire process. The thing that I've seen fail more often than not is when I'm a health provider, describe a problem to a technologist who thinks she understands it, goes away and comes up with a solution that is about 15 or 20 degrees off from what I wanted. There needs to be that period of iteration. There's also a second problem. If you work in healthcare, you work in a very, very structured way to provide evidence. If you work in technology, you work in a very, very iterative way to provide service, to provide value. We have to figure out a way to make those things work together. We have to make sure that people listen to each other and learn enough to understand what the other one is saying.
I'd like to ask this question not only of you up here, but also of the audience. And I'll start with the panel, but the audience, please, if you've got an answer to this question, we'd be more than interested in having you join the conversation. Are there lessons that we in healthcare, I'll mention the siloedness of healthcare, or lessons and lessons that we've learned from technology, also a silo, are there lessons we should learn from other industries? Should we try to create the win ourselves, or should we maybe pay attention to what we're doing outside?
You know, it's interesting you say that. I think that when we go back to the first thing was how do you decrease the cost? And you said, okay, you know, the idea is that behavior and lifestyle, right? And, you know, mobile health technology has changed how we do everything, access to internet, text message, emails, read books, listen to everything, but it hadn't affected how we actually impact our health. Now, when you look at the ecosystem broadly, you say, okay, well, what do people do behaviorally? They go to a gym. People pay for gym memberships, right? They walk. They do a lot of the things that actually can benefit their health. I mean, if you look at sedentary activity, I mean, the risk for cardiovascular disease and cancer from sedentary activity alone is twofold, depending on what study you look at. So the idea is that you've got to look at industries like the health and fitness industry. It's critical that we engage them. And so in our model, I have a personal trainer and a metabolic specialist that works with our patients that come in. So we give them a heart rate monitor, but they're taught how to use it, right? They're taught how to use it, and then they use the app and how to use the app. We have a nutritionist that engages our patients on how to use, whether it's Fat Secret or My Fitness Pal or any of these other apps. We have people that have enabled those things. So in terms of other industries, you've got everyone working, not only the devices are siloed, but the industries themselves are siloed. So you got a personal trainer that has no idea what the patient's medical issues are. You have a nutritionist that rarely, I mean, as a cardiologist, I practice, 2 days a week. I see about 150 patients in a typical model, and then I see patients in my MD Revolution model. And what's really amazing is that it's like I'm stepping into the past for 2 days a week and in the future the other days, because all of a sudden, when I step into MD Revolution, it's not me delivering it. It's a team-based approach, and I know what everyone's doing. And they do it better than me in a lot of situations. So in terms of learning from other industries, absolutely. I think we need to engage personal trainers and health coaches and people like nutritionists that are doing things. And then the other thing, too, is you got to look at the setting. You know, one of our clients right now, the Grove in L.A., which is a shopping center, retail shopping center. It's 20 million people, and they're like, we're interested in possibly putting one MD Revolution right there, because that is something that is going to bring in the retail and the environmental and the design elements that need. So we need to start thinking about healthcare outside of the doctor's office and start thinking about it in every place we go, like a Starbucks. And I think that's the way that I think the vision of healthcare is going to really go if we expect to really come up with solutions on how to solve this crisis we're in, which is going to be quite a crisis.
I actually wrote a piece recently about how Kodak, we can learn a lot from Kodak and Instagram as a potential idea of a comparison. I grew up, my dad worked for Kodak, but if you think about what happened last year, Kodak went bankrupt. And I grew up in Rochester, New York, where like 70,000 people were employed by Eastman Kodak Company. Last year, they declared bankruptcy. And the same year, Instagram sold for $1 billion, 13 employees. And when you think about what they did two things. It wasn't just digital photography that killed Kodak. I mean, Kodak was almost doomed from the start because the technology itself just totally obliterated half of their business, which is film and paper. In fact, more than half of their business. That was their main business. And so technology just got rid of that, and they would have had to lay off a whole bunch of employees anyway. But when that came around, there still was an option. It was still, digital photography was okay, but hooking that to social media, that suddenly made it so that we could do the two things we want to do with a picture. Number one, take it and not have to bother sending it off and do the rest. And number two, share it with people. And those are the two things that had to happen. And if you look in healthcare, when I think about how this is such a huge industry, how is it possible that this industry is ever going to change, because it is just so ravenous when it comes to eating dollars? And the answer is it's got to be disrupted from the outside. I don't think it's going to happen from the inside. I think it is going to be disruptive technology, and it will be my hope is that it would be a system like I'm trying to make, where I'm not motivated to bring my patients in. I'm perfectly happy to leave you out of the office and to handle your problems over the phone, or take a picture of that mole, depending on where it is, or whatever. All of those types of things. I want to know, but just make it simple, make it easy. And, that's, if you can do that using both the technology, and I really don't think it can happen outside of, well, at least there's no way I could make it work in our current healthcare payment system. But I think that combination could be incredibly disruptive and save a huge amount of money.
Thanks, Pat. So I think to your original question, Pat, are there other industries that we should be looking to? I think we have no choice. There really aren't good examples in healthcare, right? We're so new to this. It's so immature in the healthcare market. That's the advantage we have, is that we get to look at industries like banking, the airline industry. I mean, just a quick show of hands from the audience. How many of you use online banking? Wow, look at that. How many of you use a mobile application to do your banking? Okay, so a little less. And how many of you routinely cash checks on your mobile device? Okay, so again, I think that's a perfect example. Right now in healthcare, we're trying to lay the foundation with EMRs, right? We're trying to get this basic paper-based systems and digitize it, essentially. And then we're hoping to innovate it and do things like we're talking about in mobile health and telehealth. But if we look at banking, look at all the innovation happening in banking now. It certainly took time to get there, and it's still taking time. Everyone in the room raised their hands with regards to online banking, but a significant half of the room only raised their hands with regards to using a mobile app or online or cashing a check with their mobile app. It'd be great if next year we could say the same thing and ask you how many of you picked up your prescription on a mobile app. I'm guessing it may not be next year, it might be a couple years after. But I think that's the beauty of looking at other industries, and the advantage we have in healthcare is to look to those and look at those lessons learned, because I don't think this has to be complicated. I really don't. I think that simple is better. And I think the other thing that's really important to remember as we try to make these connection points in mobile health is that medicine, clinical medicine, healthcare, it's very personal. It's a very personal thing when you have a conversation between a patient and a doctor. And I think that as much as the promise is there for technologies to automate some of these, there's also an opportunity to personalize a lot of this. The smart devices, the smartphones and devices that are walking around the room, I've seen you guys out there. You've got stickers on them. Some of you have bedazzled phones. Some of you have, different colors that are like your alma mater's colors. This is very personal, this mobile health thing. And so I think that the disconnections happen by connecting those points and really, again, making those integration points happen so that we don't keep having these silos. And that's what other industries have done, and that's where they've found value.
Can I add one more element on the bringing other industries in? I think that also you have to look at, we talked about health and fitness, personal trainers, and you got, how the health industry does it, but you got people that have, take vacations, you got hotels, you got places that you go that should start adopting integrated models in a retail type setting. So if you look at, what you do at the Apple Store, when you go to the Apple Store, you buy a product, but it's not really a product that you're buying. What you're buying is the experience, right? You're buying an experience. You're buying the ability to go and ask a question to somebody at the Genius Bar when you have a problem, right? You're buying a product that works, that delivers a particular item for you. The laptop is just part of it. So I think from mobile health technology, we need to start thinking about integrated models that it's not about the mobile health device. It's about how it connects things. And so part of the issue is that in delivery of this, what we've learned is that the focus is our mobile health bar. It's not the Genius Bar. So you actually now have an IT person that sits in the middle of our practice and shows every single person that comes in, every patient, they show them how to use the app. Because listen, I don't have time, and I know most people don't have time to sit and spend 2 hours to figure out how to sync their Fitbit with their app. And then, but if you have someone there who's actually built it out for you and helping you use that product, it makes it a lot easier. And so that's why with over 200 people, we have data from 50 consecutive people, and you've seen statistically significant reductions in visceral fat, you've seen reductions in body fat, you've seen improvements in VO2, which are linked to reductions in mortality, and this is in 41 consecutive people. Why? Because we make it easy. And so people, when they come for a product, they're not coming for mHealth, right? They're coming for the experience of being engaged and taking ownership and feeling like they're in control. And I think that from borrowing from other industries, I think there's two ways to look at it. One is looking at other industries, how they're doing, but it's also the delivery model we have to borrow from other industries and how we deliver it. We have to pool expertise, because I can't sit here and show someone how to use an app. I don't have the time. The doctor's not trained in that. We're not trained in delivering that kind of stuff. So you got to bring in from other industries to help deliver the model, and they are not going to come from within. It's not going to be the nurse that does it. It's going to be the IT guy that works at the Apple store that you're going to bring in and actually have them teaching your patients on how to use the actual app. And the person that takes the blood pressure in our office is not a medical assistant. It's just somebody who actually understands how to use mobile health technology to take a blood pressure. So we do have to start thinking about ways in which, because a lot of the prevention and the cost cutting is going to come from behavior and lifestyle. So that means that we've got to take from industries that impact behavior and lifestyle.
I'm going to double back to the players in the mix here in just a moment. But, sir, I see you're welcome to join our conversation.
Thank you. John Melling from Top Tier Consulting. You've raised some really interesting points over the course of the discussion so far, and I'm not hearing any conclusive answers, and I don't think there are any, so I don't take that as a criticism. I think it's just a fact. Talking about other industries, first of all, I think when you talk about banking, they had a very specific problem that they were able to solve with mobile technology, how to get cash out of the wall rather than out of an office. And I think when you try and draw the parallel with what we do in a doctor's office, the problem is a lot more complex. You raised the issue about terminology. I think we still haven't come to terms with the standard terminology when we talk about healthcare. Everybody talks about it in slightly different terms. The point that you raised, Doctor, about the use of EMR and how that was yesterday's news and how difficult it was, and the incentives aren't necessarily in line to make people want to use it. It's a question of having to. We still have difficulty because getting information from other points of care into that system so you can act on it is a problem. Coping with the avalanche of data that will be caused by the use of health information exchanges and then importing that into your EMR is a challenge. And now we're saying to the population out there, well, now you've got your smartphone, you go use it. Well, go find an application, and one, oh, by the way, it better be one that we can rely on in terms of the quality of the information and how you get that information and how you transport that back to your doctor so that you can carry on that conversation, not so that one person's speaking Chinese and somebody else is speaking English, but we're both speaking the same language. So I know I'm just raising other issues that go around the use of technology, but I think it is much more complex when we're talking about healthcare. And there isn't a single problem that we're trying to solve here. There are lots of problems that we're trying to solve. And now we're saying, well, we've got mobile, so it becomes easier. I don't think it does. I think it's just another layer of complexity.
Gita.
So, I think you're absolutely right. Banking is certainly, I would say that healthcare is more complicated than banking, and I agree with you. But I think that the bottom line is there are a lot of problems in healthcare, just like there are in banking. Every one of those problems can't be solved by technology. I still have had issues with my bank, despite the coolest apps and devices that are out there. So I don't think that we're saying that we can solve it all and we can figure it all out from other industries. But I do think there are a lot of things we can learn because there's so many problems in healthcare that even if we take one element of that, right, whether it's discharge summaries, understanding your discharge summary, or how to make diabetes prevention important as we think about childhood obesity and using gamification and things like that so that it's fun to lose weight and not just focus on diabetes per se. So I think that's important, but I think the other element you mentioned is critical in terms of the language barrier, if you will, in healthcare. And I don't even mean multicultural linguistic things, but just the fundamental, what the hell did the doctor just tell me to do with that medication that I can't spell or pronounce, right? And so I think that's also one of the things we can learn from banking because, again, when you look at your accounts, right, you have a savings account, you have a checking account, you have, whatever you might have for investments, the bottom line is, as a consumer, I can understand that information. I understand that what's in checking and savings needs to go up, and if it's down, I need to do something about that or get a different job or pursue higher education, whatever. But the bottom line is, for my patients, I can't say it's that simple, right? I can't say that, they've got an understanding of, okay, my diabetes is on track, I'm good to go for the next 6 months, or I'm not good to go for the next year, or I need to make this adjustment or that adjustment. And that's the opportunity, I think, with mobile health and technologies, is trying to get rid of the language barriers, the educational barriers that might be out there, and making it as simple as a red, yellow, green light for patients, so when they log on to a mobile health application or a portal of some kind, they can say, okay, on diabetes, I'm green. On my lupus, not so much. I got to do that blood work, or I've got to come in for that checkup. I mean, so again, I think it's about simple stuff, because there's just so much wrong right now that if we start with the simple things, we can really make a difference.
I agree with the simple thing. And Dr. Lamberts, you've broken out of the pack and you've moved towards, as far as I can gather, more towards a concierge type approach to care. And that's great, because I'm English, and so I arrived over here and I go, okay, well, how do I go and find care? Well, luckily I'm married to an American, so that was helpful. But, you know, one of the fundamental issues that we have in the American health system is that it is fractured and people don't know where to go for care and they can't navigate the way around it. So there was an example given this morning in the keynote about, well, why don't we set up a system so you can go and look at the list of doctors and find out which one is best for you. I defy you to find out which doctor is best for you in the American healthcare system. You just can't do it. So you go to the one who you were advised to go to by your neighbor, or you might have found him in paper or something like that. Well, maybe not, but it's an opportunity. So I think we do have challenges in terms of what do we define as simple. So simple is helping people navigate the way through the system so they go to the right point of care, and having established that, then finding ways to use that point of care to both inform and be informed about my condition or somebody else's condition and start to deal with it as a carer or as a patient. I think those are simple things. When we allow people to go off and blue sky and dream about different ways to use technology to manage their own care, there's got to be a more robust structure that says, well, if you use this type of application, you could be causing harm to yourself because it's not an approved application. It doesn't necessarily do what you think it's going to do. So at multiple levels, technology, process, organization, there are opportunities to use mobile technology, but we need a more robust structure around it. I'll shut up at that point.
When I first adopted EMR back in 1996, hand cranked computers and stuff like that. But the reason that we were successful when most other practices weren't, and it took me a very long time to understand this, was that I didn't care about the computer as much as I cared about the patient. If it didn't make my job easier, I didn't use that part of the EMR system. We just, we printed out, we still use a laminated sheet with a review of systems that people just circled on it. That was the simplest way. We could have used technology, but it was just harder. And so, I think the key is to look at the low-hanging fruit first and to go after stuff. I mean, it is incredibly complicated. However, again, I think you can dress up a monkey any way you want, but it's still a monkey, although it could probably run for Congress. But probably do better than most of our congressmen. But the fact is that until you somehow change this really malignant payment system, I mean, it's not even neutral. It's so harmful. I mean, I see harm to my patients every day, and that's really why I quit. I was making plenty of money. I was fine. I just felt like I could, my patients were getting hurt by this. And so until we don't get unwedded with that payment system somehow, I don't know how, although I don't trust Congress, obviously, then I don't know how you're going to solve it. But I do think that giving good examples of what good care could look like, I think if you build it, they will come. It's that Field of Dreams idea.
Yeah, can I comment here? Because I think that, first of all, I disagree with you. You said you're not hearing solutions. You're actually hearing nothing but solutions. So, the reality is that it is complex, but we make it more complex than it should be. The greatest impact on health that we know is simply improving your eating and exercise habits. Okay? Let's look at, half the population, 1/3 of us are obese. Okay? 79 million people are pre-diabetic in this country. Don't try to fix everything. Let's try to fix the things that we can fix. And the solutions you're hearing are actual model systems. Build it and they will come. I have proof that we have over 100 people that are willing to pay for a program that delivers technology to them to help them be more engaged. So, you know, I encourage you to go to our website and look at our white paper because it shows our outcomes. And, you know, we actually we track it because I'm an NIH-supported researcher, so we're tracking everything. So, you know, what you've heard here is that the solutions are simpler than what we make them out to be. We want to make them complex, but the reality is get people to eat right and exercise. If you get them to eat right and exercise and do it with precision, you solved your problem. You solved a very big problem, not only in this country, but other places too.
Thank you. And we've got we've got another questioner right behind you that I want to get to.
I just want to add, I think the MD revolution is headed in the right direction relative to other industries and other successes. I mean, because when you look at health, and so far in the conference, it hasn't been so focused on this, 90 to 95% for most people is not the healthcare system. I don't want to bust your bubbles there, but it is about where people live, the communities they live in, the technologies they choose to use. My name is Shauna Koss, and I'm Koss on Care, but I'm also on the board of a new organization called Health in Place. And it's about using all those vehicles like OnStar on board. So if your car can get you help in an emergency, it can also upload any critical information about you if you're in that emergency. So there are just a lot of mechanisms and avenues, and it is about leveraging the tools that already exist in creative ways and creating a platform that speaks to the individual in their community in the ways that they use and gather and share information.
Yeah, I think you're absolutely right. Rob mentioned that the current system is broken. Part of the reason that it's broken is because if you look at other industries, where's the value? Most of the value is in commerce, in the movement of ideas, in the movement, usually electronic movement. Look at healthcare. What if we can deliver or transmit information from where it's originating to where it's needed at a time that it's actually needed? You know, we talk about the commerce associated with scheduling an appointment with your doctor, going to the doctor when you're no longer not feeling poorly or your health status is not really well determined, as opposed to being able to have an intervention when it's actually needed where you are. We can wind up doing this. Mobile is not a panacea. It will not solve the world, but it's a way of starting to push us into this revolution that we actually need to have if we're going to wind up being a healthier people.
Let me refer to a response that Samir gave earlier when you were talking about the fact that the team now consists of a metabolic specialist, a fitness specialist. You mentioned having an IT person working with a patient who comes into an office to help them engage in the apps so that they understand it when they go to the office. It raises the question for me, when we call it the healthcare team, do we need to disrupt what we had thought of as the healthcare team?
I think that, listen, you know, we have the best laparoscopes in the world that can take out tumors. We got the best chemotherapy that can treat cancer. We've got the best organization built around a disease care system. So do we need to disrupt the system totally? No. I think the system works really good if you have disease. I wouldn't want to go to MD Revolution if I have cancer, right? That's not the idea. What we want to do is say, here's how you need to prevent these things, okay? If you look at the system that is in place for prevention, you're absolutely right. We need to disrupt it completely, and that's what we've done. And beyond that, I can tell you that I'm able to maintain a practice of 150 plus patients a month on a part-time basis as a cardiologist, and I challenge many people to know, I don't think there's too many part-time cardiologists usually. Your patients are pretty, so the other days of the week, my staff manages this practice, and together, their salaries are less than a half what you pay one physician, okay? Now, they're in the audience here, so, you know, I think they're going to be really angry when I've written that. But the thing is, the point is that, you know, the reality is that we are cutting the cost of healthcare. We're showing it because you don't need to deliver those solutions with people that we traditionally had delivered it with in healthcare. And that's why I talked about the retail setting. I talked about these settings. To start thinking about healthcare, preventive care, differently. Because that really is where mobile health technology, in my mind, has an impact, not just here, globally. India, China, Brazil, places that have contacted us. I think those are the things that I think are really important.
So Pat, again, I think you're right, but I think the most important part of the healthcare team is the patient, right? So as we look to patient-centered medical home, as we look to the ACO model, there's no doubt that the focus needs to be on the patient, an empowered patient, and a patient that wants to have, better diabetes management or better diabetes prevention, and so on and so forth. And, the gentleman that was up at the microphone earlier mentioned some of the barriers in healthcare. What we have in healthcare right now is patients who want to be empowered but don't know how to. And to the other woman's point that came to the microphone, the majority of healthcare is not experienced or practiced in the hospital, in the emergency room, or in the doctor's office. It is experienced in my patients' homes, in their office, in their gym if they choose to go to one, in their community if they have one and belong to one. And so the opportunity that mHealth brings is the opportunity to have an empowered patient with the patient at the focus, the patient in control, with whoever they want from their team. Because I think the key and the difference that has to be made in healthcare today is that we do have to all take responsibility for our health. We do, but part of that is knowing how to. How do I, not suffer from a really bad upper respiratory infection like I am in December? Well, hey, you need to get your flu shot. Well, hey, have you had your blood work done this year? Is something on the horizon for you that's predisposing you to have this upper respiratory infection? So patients want to know. I think that's the difference, too, is that because of mobile health and mobile technologies, period, these devices go with our patients everywhere that they're at. And so if healthcare can be that much easier for them to manage and control at home or on the go, which is where everyone is, then it's going to be a different consumer. It already is a different consumer. I have patients who come in and say, Doc, there's this thing called a Fitbit. There's this application called yada, yada, yada. What do you think? Should I use it? Is it not good? Is it good? And again, this goes back to my point around the innovation or the connection points need to be integration. It's these applications, mobility, it's only as good as we are as a community of being connected. And that's really going to be the future of mobile health. It's not just, digitizing everything, but it's now connecting everything. That's really the value proposition.
As I've been thinking through my model, which again is about $50 a month per patient, give or take, trying to make it affordable for people, but it's freed me to think of things along the line of being able to contact between visits and then start saying, well, how important are visits? And the reason that office visits are important in the first place, and the reason that I had to force most of my patients to come in to talk to me about stuff that didn't really, 80% of the time didn't need to come in, is because otherwise I wouldn't get paid, period. That's the only reason. If I could somehow get paid to handle a UTI over the phone or in a reasonable sense, still practicing good medicine, but a lot of the history can be taken using all of these technologies. And then as I'm thinking about it, it's this whole idea of the care continuum. Because the truth is, the way that I've looked at care in the past, and I think our payment system forces people to think this way, and I think we docs are really the guilty parties, probably as much as anybody, of getting the idea that health care happens in the exam room. And that's it. And once patients believe that they can't get health care, guess who owns their health care? It's not the patient. It's the doctor. It's the doctor's going to tell me to do this. And so they kind of have put this care on me or put this care on somebody else. And I really think that mobile technology especially enables me in my circumstance, now that I've just basically, thrown out the old system and put in a new one, that enables me to engage the patient and ask them to engage me. I want to know if they're seen for depression. I will use a questionnaire or use some sort of a mobile contact to get in touch with them on a regular basis. Or I want to know, and again, this does involve bringing in other folks, and people mention the medical home. I really believe the problem with the medical home is that it's a top-down medical home. Truth is, in my system, if I grow enough, then I'll just hire a social worker. I'll just hire a dietitian. I'll just hire a pharmacist. And those folks will do a better job, like Samir is doing, the whole idea of they'll do a way better job than I will of explaining what you should eat, or exercise, or taking care of all these social problems at home, which, again, the average person is dealing with that. Hire a counselor. Those are all our possibilities.
So I think one thing that both you guys said, and you said patient ownership. You're talking about the patient needs to own their health. And one of the things I think we didn't get a chance to talk about is what actually mHealth does. When I got my Fitbit, which I'm wearing right now, and I've got 1,900 steps today. Now the guidelines say 10,000 steps. If a population alone walked 10,000 steps, the amount of savings we would experience as a society is, I can imagine, it would be in the billions of dollars, multiple hundreds of billions of dollars, just by getting people to do that. And what we find our patients tell us in our model is that the two things that they find is the most compelling is the fact that they're measuring things. It's the whole management theory. If you can't measure it, you can't manage it, right? So number one. Number two, they love the fact that somebody is monitoring it. It's actually, so just this weekend, we have people all over the country that come and see us, and then we monitor them. My metabolic specialist last night showed, via her app, 4 people how to actually do their heart zones, because so many of us exercise. You go in the gym and everyone exercises, right? So it's not, it's not just going out and exercise, it's being precise about it, right? There's actually interval training zones that actually improve your VO2 levels, fitness levels. And we can use that now by simply giving a person a heart rate monitor. And I think you guys will tell me, when you ask people, do you exercise? They're like, yeah, I rake my leaves in my backyard, right? And I was like, that's not exercise, that's physical activity, right? But people think that's exercise, right? Am I right? Do people tell you, like, do you exercise? Like, oh, I rake my leaves, right? And as a cardiologist, I ask a lot of people that. But the reality is now I give them a heart rate monitor. I'm like, listen, look at this DigiFit app. If your heart rate's not X, then you're not exercising, right? So now all of a sudden they're measuring, and then we can monitor and motivate. So the paradigm, measure, monitor, motivate. That's the paradigm for prevention. I think that mobile health enables.
That's super. We've got time for just a couple of quick questions, and I see some gentlemen lined up. So, sir?
You've talked a lot about the mobile access for the patient, and you just briefly touched on some mobile access for the provider. Can you talk about that side of things? Because there's a whole other end of that that seems to be missing, both from a access of information and communication, but also there's a security aspect. I'm all with you on measure, monitor, motivate, but if I find out my neighbor now knows my blood pressure and my cholesterol, I don't think I'm happy about that.
Well, I think that what you have to do is you have to merge Facebook and what's the largest, Epic, largest EMR system? You merge them, right? So you have to have, so our software is HIPAA compliant. It's all HIPAA compliant. And the TuneNet platform, which we use, is HIPAA compliant. So all the data is actually completely secured. We have our own database. And so the reality is the security, while it's extremely important, you're absolutely right, it can be managed, and we're doing it. Number two, in terms of the actual data stream, the nice thing about it is that, when you use the TuneNet system or you're using mobile health devices or genetic information, you can program the system to send alerts to the healthcare team. So our healthcare team is not looking at each person's data. We're not looking at, Joe Smith's data. We're looking at alerts. So my health coach or my medical assistant in the office is basically sitting in front of her computer and saying who didn't walk 50,000 steps for the last week, who put on 5 pounds in weight, who went to D.C. and drank too much, and ended up eating too much and logged things, or who's not getting enough vitamin D in their diet, right? All this stuff can be done. Fat Secret has an API. DigiFit has an API. These all can go to software in a HIPAA-compliant fashion through TuneNet. So I think that, the issues you raise are extremely important, and I think that, there are solutions.
Thank you. Sir?
I just want to make a comment. My name is Doug Nagley. I'm with Infield Health. I want to make a defense of the big blue sky idea and not incrementalism. So I'm worried if we focus on incrementalism and low-hanging fruit. That's the low-hanging fruit that's available, which may not be the best projects to do with the most impact. And I'm worried if we focus only on incrementalism, we'll be back here in 3 years talking about, well, we got readmission from 19 to 17%, where it really should be to 5%. And I think the recent history of technology innovation is the blue sky idea. I mean, the first Toyota Prius wasn't a gas car with an electric engine taped to the roof, right? And iPhone isn't a Palm Trio with a browser. There's They're new things that are the blue sky idea that move everybody. So I think there's room for incrementalism, and maybe that's the IT department of the provider, because they are in the business of incrementalism. But I think for technology innovators and startup guys, the blue sky thing is the thing. And so maybe there's room for both. Maybe I can concede that there's room for both. But let's not kill the blue sky idea just yet.
I would like to, honestly, I'd love to continue this conversation much longer, but in respect to all of you and your timetables that you're keeping today, unfortunately, our time is up, and I need to draw the questions to a conclusion. Ma'am, I invite you to come up afterwards, though, and certainly engage us.
Well, if I could just say a word, because I apologize for disrupting this, but it seems to me in this whole conversation about the disconnect between mHealth and mobile technology, I'm a physician myself, but it seems like what's missing from this whole morning is the patient. And maybe part of the disconnect between mHealth and mobile technology is that we haven't really engaged them in these kinds of conversations enough.
You know, that's the perfect summary comment for the panel. And I thank you. I thank everyone here for your time and attention. And please join me in giving a round of thanks for the panel.